Having that EMS dispatch recognize this is a priority is part of that. The delivery, we're going to look at each of these in a little bit of some detail. Getting them on scene and getting EMS off scene is really important. EMS should have goals for stroke patients on getting off scene, okay? Typically, they want to be out of there within 15 minutes, no later than that. So they want to get in. If it's a stroke patient, they want to do their quick assessment and get out of there because they want to get them to their destination. And again, getting to the door, immediate ED in terms of triaging. What do we need in terms of data? I need a blood sugar, I need a non-con head CT to make sure, to see about their eligibility for thrombolytics. And then we need a decision about what therapy we're gonna provide and what drugs are we gonna provide. Do y'all use T&K?
Mm-hmm.
You do, yeah. Thank goodness, right? How convenient to just give a bolus of T&K and moving on. You don't need that 2 IV business and all that kind of stuff. And then transfer into a higher level of care. You're probably getting all the transfers in. Y'all getting all the transfers in? Yeah. And then the device. Okay, so that rapid transfer. So community awareness. Many stroke patients are really vulnerable because they can't communicate that they need help, and so and some of them may not even realize that they even need help because of neglect. So they may have right-sided strokes and not even realize that the left side doesn't work very well. Okay, they may not have access. I don't know how many times patients have been found down in their yard, or their daughter comes in and can't reach them. Or another situation like that. And then less commonly, loss of consciousness and or confusion. So again, we have billboards all over our state. Be fast, call 911, I'm sure you do too. And so it's all about that community awareness, okay? And then having them call 911. Up to 65% of patients are transported by EMS to the ED, and that's really good because they can actually get into the door. They come in private vehicle, that makes us crazy. We had a physician who really was denying the fact that she was having a stroke. Our family said, no, you're having a stroke, and she arrived by private vehicle, knowing better. But anyway, she's okay now, but she really had a neglect syndrome. Mm-hmm.
What would your advice be to somebody who lives like an hour outside of town or something like that? Like they don't have local EMS? Because recently I was discharging a patient doing stroke rounding, and I was like, you need to call EMS. And they said, I can get to the hospital in 30 minutes if my wife drives me. If EMS comes, it'll take me an hour to get there. Like, what's your honest advice?
So in a rural situation like that, I think you continue to talk to EMS, meet them in a parking or something, because they can get them in the door.
Still call 911, and that's kind of what I told us, like, call 911
Still call 911
and tell them what.
And say, hey, I'm moving. I think, because what happens if they have a seizure? What happens if they have any of those other things? You know what I mean? You have to be reasonable too. In a rural state like us, sometimes I have like first responders. They're not even paramedics. They're not even basic BLS certified. So in a case like that, I think you have to do the most reasonable thing you can do to get them to the door. The problem with private vehicle is when they come through the ER triage, typically it's just a support person sitting there. And so they don't get right through the door straight to CT is part of the problem. But I think if you keep talking to them and say, hey, I'm on my way here, can you meet me here?
Right, and that was the advice I gave them. I was like, call 911, start moving towards the hospital and tell them where you are.
And tell them where you are, that's right. That may be the most reasonable response in a situation like that. Yeah. So again, most of the calls are made by family or friends, and we had one patient, we did some education at the ball field, was called by, you have instances where they're called by kids. Maybe the grandchild is calling for grandma. When failure to call EMS is associated with lack of pain, because in most presentations they have some numbness or maybe they have some weakness. consciousness, obviously, and less severe stroke symptoms that resolve. And female gender, I don't know why. I mean, we can call EMS, it's okay if we need them. Other factors with EMS include minority race, hemorrhagic stroke, maybe those patients are down and they really can't communicate. Increased stroke severity, same thing. And unemployment because they don't know how that bill's gonna be paid. They're worried about paying the EMS bill. I can tell you that right now, I don't wanna pay that bill. I don't have any insurance, that kind of thing. People are still worried about that. When we talk about dispatching EMS, obviously our ABCs and our disability assessment. We're gonna talk about evidence-based stroke scales in just a moment. EMS is really good about getting the critical information that we need right now about last known well or last seen normal, and getting that to us. They're also really good in my area about giving us a phone number because families aren't traveling with them in most cases. And so they'll get us a phone number and a family member who's available that we can talk to. And now that we have care everywhere, and we have electronic medical records that can look back at previous visits, I can see if they were here last week, I know what meds they're on. And I know if they're in another clinic or been to another hospital, I know what meds they're on at least at that time. So it really does help being able to, even before they get there. We use, our EMS can activate our notification system. We use Pulsara. Do y'all use Pulsara? We use Pulsara, so EMS can activate that in the field and for a stroke patient, and then we can start looking that stroke patient up in our medical record system, so it really does facilitate the medical history taking and so forth. They don't stay on scene very long at all. They're one of their quality metrics is to get out of there in less than 15 minutes max. You know, obviously unless they do some ACLS or something. So we're gonna look at, I'm gonna click through all this so you can see all this because I don't like it. Okay. All right, early on we used several different scales. The Cincinnati is the fast. And so the T is now referred as time, but it did refer to just the speech test, and it's just face-arm speech. So it's the fast. And they scaled down the NIH to develop it on the Cincinnati pre-hospital stroke scale. The Los Angeles pre-hospital stroke scale was developed by stroke experts, but we'll see in just a minute, it has a little bit, and it's convoluted. I mean, it seems really complicated when you're in the field and you're trying to get a history and all of that, and you're trying to get out of the door. Some of these people are not easy to move out of a house. And so the Los Angeles scale we'll look at in just a moment. The men, did y'all do ACLS? I mean, ASLS, Advanced Stroke Life Support course here at all? Okay. The MEND is the Miami group did utilize this, and it used all the elements from the Los Angeles pre-hospital stroke scale, the NIH, as well as the Cincinnati. But it also had head trauma and subarachnoid hemorrhage. But again, it was limited because they only called it a stroke for symptom onset less than 5 hours, and we know now we have expanded that definition. So a lot of people don't use these anymore. Just so you know what the Cincinnati looks like, again, is the face, the FAST, the face, arm, and the speech, okay? The Los Angeles pre-hospital, look how cumbersome this is if you're an EMS provider. I mean, and obviously they're gonna get the last time, date, seen normal, but they limited to age over 45. We have stroke patients who are younger than that, and so if we have that as an age limit to call a code stroke, we're gonna miss patients. Again, measurement of glucose was important here, and that's always important for EMS. But again, that part 2 is the physical exam, which is and they use grip as well. So it's facial grip, arm strength, and unilateral weakness was the score that was used here. Yeah, what do y'all use?
BFAST.
Use BFAST. We do too. It's easy. It's easy for patients because then you can so we use BFAST. Our EMS uses BFAST.
They're just about to switch to BFAST.
Yeah. Yeah, we moved to BFAS because it was, I'm like, why are we having all these scales that don't translate to the community? I mean, we should all use the same, screening scale. So we use BFAST as well. And BFAST, again, to reflect the balance in the eyes, okay? In
But
addition to the facial and speech.
We're gonna change to the Cincinnati?
No, EMS, Ada and Canyon counties use Cincinnati currently.
Oh.
They're gonna change to BFAS.
I was like, that seems backwards.
Oh,
Okay.
I was gonna
Yeah.
say, like, cause we have the little magnet cards for BFAS that we just give to people, be like, hey, here you go, just in
Oh,
case.
it's Cincinnati.
Yeah, no, okay.
Yeah, I know, and it just doesn't translate. It's really nice if you can just have a consistent thing with the community and the EMS know about it, right? So, BFAST seems to be the trend, going around the country. I mean, it's easy. If you're trying to get out, then it's easy. So when you go from dispatch to delivery, there are two most common, these aren't the only ones. What do y'all use for your large vessel occlusion scale? Use a
Van.
race or a van?
We use Van.
We use van, yeah. Our EMS will use BFAS plus a van. So if it's BFAS positive, then they do their van screening. And if that's positive, and if they're close, they have protocols. I mean, they'll skip a primary center and go to comprehensive or thrombectomy center. If it's pretty close in time, okay? So the race scale ranges, the points are 0 to 9. And so scores over 5 would suggest a large vessel occlusion. The thing about the race is it evaluates the leg weakness too, not just arm weakness. So it also looks at head and gaze deviation. Okay, so it looks at all these components: focal motor, facial motor, arm motor, leg motor, gaze deviation, and aphasia. So it scores them for aphasia and agnosia, right? Can they recognize their arm? And, I always say, I always ask people, especially with right-sided strokes, whose arm is this? 99% of the time, they'll say, that's my arm, if they can, and they'll say it really slurred. But occasionally, you'll get somebody and they'll go, and so you know that they got a pretty significant neglect in that situation. But the race again looks at their leg and their gaze and also their speech as well. Van is easy. If you're trying to get out the door easy, it's easy. If you are positive BFAS, in other words, you have arm hemiparesis, and then you have, van is really a visual disturbance, aphasia, or neglect. If you have that, it's suggestive of a large vessel occlusion, okay? So any van signs positive might lead you to conclude that this patient might have a large vessel occlusion, and so you're gonna take them to a comprehensive center. And there's a lot of differences in the protocols with EMS too, because a patient who's in a thrombolytic window with telemedicine now in rural areas, we have a lot of rural areas and we use telemedicine. And so you don't want to eliminate an opportunity for them to be able to get thrombolytics. But if they're out of a window for thrombolytics and they have all of this, they're gonna bypass that because there's no thrombolytic to give. So EMS is really, they really do care about their protocols for how they do this. And the American Stroke Association's made several recommendations about destination routing and that kind of stuff. Okay. When we talk about, I'm gonna get through all of this stuff right here. Oh, hang on a minute. Sorry, there we go, that's where I want, okay. So, they have standard things that they have to do, and they are governed by the medical director. So the EMTs and the paramedics work under protocols that are approved by the medical director. This is the reason why in my state, and it's state by state, in my state, they can't titrate drips. They can't titrate carding for blood pressure. And so we've had, they have to call and get a specific order from the medical director to be able to titrate a carding to go up from 5 to 7.5 or whatever. And so it's a real tedious process, to use. It's easier if you have one system. Do y'all have different EMS systems? I mean, like providers here? So you have to go through multiple medical directors to get stuff done? Yeah. It's a pain. It's a real pain. But again, this is what they're gonna do, IV access, oxygen. And that SpO2 may be, seems a little high to me, put oxygen on somebody, less than that, but there may be some differences in that number, depending on who that EMS provider is. Again, blood glucose, nothing by mouth. Pre-notification is really important. We're pretty high on that, on the pre-notification, for EMS, so that we're ready, so that the team is ready. And again, they pre-notify from the field if they can through Pulsara. So that way we have a patient and we can look that patient up before they ever get to the door. Okay, not recommended, these are important for you to know. Dextrose containing fluids in non-hypoglycemic patients, not recommended. Moving the blood pressure down, excessive blood pressure reduction, they don't touch that blood pressure because they don't know what's wrong with that patient. So they don't touch that blood pressure, and they don't drown them in IV fluids either, okay?
So our book just says should not give solutions that contain glucose. Should we add the little caveat unless they're hypoglycemic, then it's?
Yeah, if they're hypoglycemic, they're gonna treat that because that's a stroke mimic.
Yeah.
So they're gonna give a little bit there,
Yeah.
and then they'll recheck the blood sugar. Let's talk about air transport. Obviously, we can get people faster with air for the most part, even in hospital transfers, even in large urban areas. If you try to get an ambulance around Manhattan, disaster. I mean, you know, and so air transport is sort of really increasing its presence, and insurances are starting to better reimburse that transport. And they're starting to do contracts, which means that, you know, you have to sort of limit what you charge. When you have these insurance contracts, you sort of contract the cost of the services. But again, the availability remains limited in many areas, and you're also limited by weather as well, okay? The cost of transport can be really high because of your personnel that you need and the expertise of those people who need to be on the chopper, as well as fuel and equipment. So again, y'all have air? I mean, you have air here, I'm sure. Yeah. Usually we will fly them. What I have seen though is I've seen sometimes where we didn't vet the patient, and this patient was really a palliative patient, and we didn't vet that patient before they were put on a chopper here to Little Rock. And so that's a case where you just go, oh, you know, I wish I could have just talked to the provider there and said, look, we will get them here and we will take care of them, but there's really nothing we can do. This patient's gonna be a complex care patient. There's no intervention we can do, especially in hemorrhages. So it's really, it's a little bit, it's nice when it's a large vessel occlusion and you go straight to the lab and you pull the clot, and that's nice, but it's really nice when you just think, oh, I wish we had talked to you before you stepped on a chopper. You know. Mobile stroke units, do y'all have mobile stroke units here? Okay, we don't either. But anyway, but just so you know, they do exist around on every continent. And they're typically, they have CT, they have capability for non-con head CT. They also have capability for CTA. So because of that, they can diagnose a large vessel occlusion right there and get that patient to a thrombectomy capable or comprehensive center because they have that capability. But anyway, but in the early 2000s, the first mobile stroke unit emerged in rural Germany, and again, they're operational throughout the world. They can treat many more patients within the first 60 minutes of stroke onset than hospitals receiving standard ambulances. They've delivered TPA, they've met ambulances in parking lots. And so they also work with ground transport to meet them, to shorten that time frame, because they can do the imaging and they can do, and then they can rule out hemorrhage. And if they're in a thrombolytic window, they can give that and then run the imaging and then give them to a comprehensive center. So it's pretty nifty. But I do know, at least the one in Memphis, I know that, and this is the one in Memphis, I do know that they will meet an ambulance in a parking lot and have done so. Okay, so again, significantly faster TPA or TNK delivery within the first 60 minutes because you have all the stroke experts you need on the scene. You don't need all the bells and whistles of an ER necessarily. You also can enroll people in clinical trials with MSU faster. And again, improve pre-hospital triage. So now you can, once you give the thrombolytic and they have a large vessel, you just go straight to thrombectomy capable or comprehensive center. And you bypass the ER, so you get a direct admit that way, okay? Now that you have a CT, if they have a hemorrhage, now you know what to do with them, right? So now you can decide, do you need to lower that blood pressure, or do you need to lower the blood pressure so you can give a thrombolytic? That's the other thing too, is that you don't have to ask anybody. EMTs have to ask, paramedics have to ask. These things are, they are staffed by nurse practitioners who can decide that. They're staffed by providers. And again, significant improvement in 90 days. We always did Alteplase before, but now we're transitioning over to TNK.
Are these usually partners or like part of the local EMS teams that sort
They
of
can be,
manage
they can be.
these,
They're typically hospital-based
Okay.
because of the cost, because a hospital's a deep pocket.
Right.
And so they're typically hospital-based, but they do work with the local EMS because the EMS realizes they don't want to sit on a wall.
Right.
Is that
And-
mostly like urban areas where it's gonna be a pain in the rear to get to the hospital?
It can, yeah, because in Memphis, they use them that way, yeah. So
You
it
brought
can,
up
it can be.
Manhattan and driving around, if someone can get to you.
Yeah, if you can
and
meet
start
somebody, if you can
treatment.
meet somebody and expedite the thrombolytic treatment and then expedite their destination, then they'll use it that way, yeah. The problem is when you have the bean counters and they do the cost benefit, you know, if you're not using it a whole lot, it's costly.
Yeah.
It's really, really costly. One of the things that's really helped us most is telemedicine and telehealth. In terms of getting people to that thrombolytic treatment, we have a statewide telehealth. We have two. Do you guys have telehealth here in rural areas? Yeah. It has really made the world of difference because ED physicians do not want to make a thrombolytic decision. They do not, and they will not. They will not. And so it's really effective in terms of getting these people triaged and getting that thrombolytic treatment. Okay, and now it's pretty easy. I mean, to do telemedicine, it's relatively easy, and so it's a lot easier to maintain, and it's much more financially feasible.
Are we gonna see some like different, cause it lasts well-known times, like less than 6 hours, to get to thrombolytic, when I worked over at Portland.
Yeah,
I've
so,
had intensive SSA, go ahead and give it, even though it's been like 12 hours.
Yeah.
We gave it, like, we've actually seen results.
yeah, and this is where Anne and Andre, they look at CT, it's off-label. I mean, obviously it's off-label, right? But the 3 to 4.5 hour timeframe is off-label too, from an FDA perspective, right? So that's off-label too. That's where they get into their imaging, is when they determine that. So they get into their CT head, if it's negative, and their CTA aspects, if their CTA, and they have symptoms, and their CT looks okay, and it doesn't show a big hypodensity or subacute or anything like that, and the CTA looks okay. Even if there's a large vessel occlusion, but if the aspects is really good, which that aspects, I don't know that we're gonna talk about that. Anyway, it's a scoring system for normal CT, and it deducts points, so perfect is 10. So it deducts points for abnormality. And so, and we're gonna see that when we get into imaging with sulcal effacement, loss of gray-white differentiation, that kind of stuff. If there's none of that kind of stuff, they're gonna do it.
Yeah.
Some of them are gonna do it, yeah.
There was a recent study that like, that was kind of, that's what that kind of came out of, right? Like there was that big big study where they were giving it outside of 6 hours.
Yeah, and the Wake Up trial, they're using MRI and using a FLAIR DWI mismatch to do exactly that, and they're going up to 24.
Like
Yeah.
I've seen like the same windows, like personally, and I'm like, really? Okay.
Yeah,
Do
but it
they,
has to do with the imaging, it has to do with the imaging that they're doing and the way that they're interpreting it. Yeah, but it has to do with that, because if it were just time frame, that's why I'm saying, if we could get MRIs that were quicker and easier and not as many contraindications, I think we would treat more people with thrombolytics outside of that window. But ER physician's not gonna do it.
do they weigh medical history into that, or?
Yeah, they have
in
to,
the
they have to
decision of
assess
the
all the
outside of the-
eligibility and stuff
okay.
like that. Oh, yeah, yeah. Yeah, they have to do that, and it should be a conversation, because it's out of, it really is out of a FDA, it's off-label. And so when you do something like that, you have to have a risk-benefit conversation with the family. Cause the last thing you wanna do is just willy-nilly do that, and then you don't have, and then you know, you have a big bleed or something like that. Yeah, yeah, but we're gonna see that here in just a minute, yeah. I know, it just, I'm just like going, yeah, but that's why they get paid the big bucks, is to make those kind of decisions. Yeah. When we talk about levels of care, so some guidelines would tell you to transport to the nearest facility capable of providing emergent stroke care. And then you have these protocols that allow you to bypass primary stroke centers, especially when they're out of a window for thrombolytics. Bypass the primary stroke center, especially if they have telehealth, because that's an additional, time delay when the severity dictates a higher level of care. So different places will have different protocols. What we found with Jennifer Patterson's, what we found with her research in terms of comprehensive centers is that moving patients from somewhere else to us is difficult, because we don't have any beds, because everybody ships to us. So we don't have any beds, right, to comprehensive centers. We may have the lack of availability of ambulances or helicopters. And then the bed availability is a real challenge. And then the process to get an available bed. Even if the neurointerventional team says, yes, we will take them, you gotta go through bed control. Then you gotta go through some other person. Then you've gotta have an assignment. And then you've gotta do all these things that delay you getting your patient in. So moving patients from a lower level of care to a higher level of care is not typically the fault, and the delays in those things is not typically the fault of the sending facility. They want them out of there. They do not want them to be there. They want them out of there. In my state, there are some counties, I have one EMS provider. What if that EMS provider is out? I have no EMS provider to transport a patient, right? That's when we'll call in air. In some cases, maybe I have two, but I've only allowed one to be out of the county at a time. And so you're delayed. So the delays happen mainly because of EMS availability and staffing and so forth, and there are restrictions in the areas that they can be out of at one time, and the comprehensive centers and the bed availability. So those lower level of care, they really do want them out. So trying to address those things, we're addressing those things legislatively because we're sick of it. So we have an interim study with our legislature. Our stroke coordinators and our regional group, they were like, oh, we've had it up to here. We've had it up to here with no solution. Trauma doesn't get to do that, Trauma doesn't get to sit in an outside ER and wait. Trauma gets priority. Stroke should have priority too. And trauma gets a quality improvement committee. We don't have any of that. We have our own isolated committees. And so trying to really look at that as a state perspective rather than just individual organizations. And so the legislature is looking at that right now. So we'll do an interim study, see what that looks like, and I bet we'll have some action on that in 2027. So, yeah, that's the team I work with. They've just had it. Rapid access to thrombectomy, again, is really important, but you've got to get them out. And you've got to prioritize that thrombectomy patient or that thrombectomy eligible patient. The early trials in 2015, when we look at reperfusion therapies, and we're gonna look at that tomorrow. When we look at that, time is of the essence to get the outcomes that they had. If we don't get them out, then our outcomes are not gonna be as good as the 2015 trial, so we have to get them out. Okay, again, in my state, we have I have 3 available facilities that can do thrombectomy. That's kind of sad in a big state. How many comprehensive centers, Kurt, do you have? Do you know?
Like Joint Commission, we have 0. But between us and St. Alphonsus, we're thrombectomy capable centers. So we have 4 hospitals in this valley that do thrombectomy, and then on the east side, I think there's 2. So
Okay.
Port Beth and Merrimack.
Ermac, yeah.
Okay.
Idaho Falls, we don't, we have to send them across the street to Ermac.
Yeah, you have more than 3. Yeah, so we have to send, so we've had to send to Oklahoma, we've had to send to Memphis, we've had to send to Louisiana, we've had to send to Missouri. I mean, it's insane, the attempt to get, and our stroke coordinators they've just had it. And then by the time I get them there, they've completed their stroke, which is really sad. Okay, triage. Triage just means to sort. So the ER has to triage these things as well. Now, when we look at our EMS providers, they're also triaging. You know, is this a stroke? Is this a mimic, whatever? But the triage is designed to support rapid evaluation. Okay, so these are the triage process, and we'll see in just a moment. Sort of a designation process that is used to identify patients that can't wait to be seen. They're gonna die if we don't do something. So the emergency severity illness, listen to me, index. It's simple to use, it has 5 levels, okay? It categorizes ED patients by their acuity and resources you need, okay? So high acuity level criteria is the ESI 1 or 2. And usually the triage nurse evaluates that. But the acuity is determined on the stability of vital functions and the potential for life, limb, or organ threat. All right, so stroke patients, all right, here's the algorithm. ESI level 1, is the patient gonna die? Do they require immediate airway? Do they need to be intubated? Do they need immediate medication or other hemodynamic intervention? Do they meet any of that criteria, right? Intubated, apneic, pulseless, any of that stuff. Is the physician immediately needed? Yes, it's a level 1. No, the nurse can initiate protocols without the MD presence, level 2. So that's the algorithm right there. They can't wait, the patient's dying. Okay? Can the patient wait? This is a 2. It doesn't mean it's not a high-risk situation. It could be a high-risk situation. And so these are conditions that can easily deteriorate. Or be a patient presenting with symptoms that would require time-sensitive treatment, okay? They still have a threat on life or organ systems, okay? And another, are they confused, lethargic, or disoriented, severe pain, or in distress? So this is the algorithm here. Okay. Oh, I didn't know all that came up like that, that's nice. Okay. The golden half hour, what is your time to T&K here?
But we use the target stroke goals.
Is it 45, is it like 45 minutes for so many, or is it 30?
50% of our cases less than 30 minutes.
Okay. So yeah, you gotta have a well-oiled machine to be able to do that, right? So suspected stroke patient, EMS pre-notifies, we use Pulsara, and it goes to the entire team, so I don't have to make phone calls, there's no phone calls. All the communication happens in the app, so the ED physician immediately knows what's going on, our neurology physician knows what's going on, our stroke APP goes down to the ED, writes what the symptoms are, the last known well, medications, all the things. All of that communication goes in there, so you're not making multiple phone calls. If you've been in the ED or trying to make multiple phone calls to multiple people and trying to get something like that coordinated, having a common platform like that really is helpful. Again, hospital pre-notification is a quality metric. Ours is about 70%. I wish it were more, but it's about 70%. And I think some of it's just not documented well. So the patient arrives, they're met by the stroke team, in less than 10 minutes, you wanna go direct to CT, so you don't stop in the bay. Y'all go direct to CT?
Don't.
You don't? Do you stop in the ER bay?
So we do this weird model, so if their EMS greater than 4.5 hours, we go direct to CT. If they're walk-ins or less than 4.5, we go direct to camera. It's seen by the neurologist, make the decision.
Oh, gotcha.
And then send it to CT with the
Okay.
hopes of delivering TNK in CT
Okay.
scan.
Okay. Well, you have a process.
Yeah, we have a process.
You have a process, okay.
It's different.
See, for me, an ED, so honestly, if they come in private vehicle, they do try to get them to CT and get the order from CT, so we just have all that done while we're trying to do all this other stuff. But from EMS, it's easy, you just, hello, we're here, and they just go straight to CT from that perspective, okay? And then your basic stroke assessment, and, I don't know why Jennifer put, IVP there, but IVP, anyway, it doesn't matter. CT scans completed and interpreted. Interpretation doesn't mean it has to be read. Now, some of our providers like for reading from the radiology. Interpretation is what you want. So the stroke neurologist should be able to interpret their own imaging without they don't need the formal read. I don't care about, I don't care about, a calcified pineal gland. I don't care about, I care about things that would exclude them from, treatment. That's what I care about. And so we wait on the formal report for all the other extraneous stuff like sinusitis. I don't care about sinusitis. I mean, I'm not looking for sinusitis. I'm looking for blood. I'm looking for a reason why we shouldn't thrombolize this patient in a patient that's eligible. And then less than 30 minutes. We shortened the time down. When I started this, it was 60 minutes, but we're better at it now. Again, stroke mimics are real. There are, not everybody who comes in with stroke symptoms is having a stroke, right? And so you have to sort those out. The good news is if you give TNK to a patient with a stroke mimic, no harm has been demonstrated in cases like that when they truly are negative. But you don't want to give medication if the patient has a mimic. And so the functional patients, those are patients who come in, I mean, it's really psychiatric, right? For the most part, the true conversion orders are really psychiatric, and I've seen that. It's a real weird phenomenon when you have a true conversion disorder. But again, I've also had patients that were identified as a conversion disorder, and guess what, they weren't. Because somebody decided to check reflexes and things like that. And so that should be the last diagnosis. That should be a diagnosis after you've done everything. That should not be your go-to of saying, oh, they're faking. I don't want to be on the other end of the attorney. So go ahead, if they have a suspicion, go ahead and get your vascular imaging and so forth. But typically these patients lack cranial nerve findings, or they lack localization, and we'll talk about that in a little bit. Post-ictal focal deficits, for sure. If you've seen a patient after a seizure, particularly with focal seizures, they can have weakness, and it can really mimic a stroke. I take those patients for emergent MRI because I don't want to miss an opportunity. If I need to thrombolize them, then we take them emergently to MRI if we can. And so MRI, again, is the most definitive. Hypoglycemia. I never forget, I was working the code stroke service during the day, and it was in CCU, and this patient had focal findings, and they brought them to CT, activated the stroke patient, brought them to CT. I met them in the CT scanner, and I said, what's her blood sugar? And they said, well, an hour ago it was 112. I said, okay, but an hour ago was she like this? Well, no. I said, well, what is it now? And so I had somebody bring a glucometer over, it was 27. And I was like, that's our problem. So we treated her, and she was just fine. And they said, Rhonda, we're so sorry, we didn't even think about it. I said, it's okay, you called the code stroke. I want you to do that. I don't want you to feel bad about doing it. I'm happy to be here, but we figured out that this is a mimic, which is good for you and good for her, because now we can actually treat that. A complicated migraine can present like a stroke. I had one in 1995. And I had a massive headache, and then I couldn't speak. I couldn't talk. And so, after my husband, we were playing games or something, and I'm not a real joker. I mean, I can be funny, but I'm not a real joker. And after they made fun of me for about 5 minutes about not being able to talk, then they were like, well, do you need to go to the hospital? And you know what I said? No, I don't. And so, anyway, but I think I had a complicated migraine. But anyway, I told him, I said, listen, if someone can't talk, the first thing you don't do is make fun of them for 5 minutes. That's not what you do with a person that might be having a stroke. So I still give them a hard time. And my oldest daughter was in on blah, 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 blah. It was what she was saying to me for about 5 minutes until my husband figured out I was getting mad. Altered mental status, yes ma'am,
Would that be like a hemiplegic migraine as well?
can be.
Is that
And
pretty
it-
common?
It's kind of uncommon, to be honest with you. I mean, in the time that I spent, seeing post-stroke patients, probably over a 2-year period responding on that particular service, I think I saw 1 out of the hundreds that we saw. So it's really kind of, it's really very, on the rare side. But I would work through the CT and the CTA, I would get all the things. I definitely get all the things for them.